Dr. Stoessl is professor and head of neurology at University of British Columbia. Previously, he was the director of the Pacific Parkinson's Research Center and also the Center for Brain Health. And he also, just when I came on as CEO for the Society, he had been the medical advisor to the board and the Society up until that time. He holds a Tier 1 Canada Research Chair in Parkinson's, is editor-in-chief of Movement Disorders, and served on numerous other editorial boards, including Lancet Neurology. He is past president of the World Parkinson Coalition and has published more than 300 papers and book chapters and been cited more than 16,000 times in the scientific literature. So thank you so much for joining us today. Welcome, Dr. Stoessl.
Thank you. So I'm just trying to figure out my screen share here. And I'm not sure if you can see my screen or not. I can't see anything now except the presentation. Are we okay here? I'll assume we are. Somebody let me know if it's not working. So thanks very much. I didn't have a problem following Dr. Lang or Matt, but it's an unkind act to make me follow Naomi, who is a tough act to follow. And I'm also between you and lunch, so I really feel like a sandwich right now. I'm just going to start with disclosures, none of which are really important except for one that, isn't listed here. I will come back to that. I chair a data safety monitoring board. Oh, it is at the top for an experimental therapy. So I have no commercial interest in this, but I am going to talk about this treatment among many others. And so you do need to be aware of that conflict. So a lot of the territory has been covered to some extent by Dr. Lang, and so I will go rather quickly through some of that. There are major interests, of course, in what contributes to Parkinson's disease, genetics being one major factor, but there are other mechanisms. Everybody's talked about the importance of biomarkers. I'll talk a little bit more about that, and then I'll talk about treatments, both for managing symptoms and also the idea that we could actually have an impact on disease progression.
Sorry, Dr. Stoessl, sorry to interject. Yep. I just
Yep.
wanted to let you know that the presentation is not showing. It's not loaded yet. It's still loading.
All right.
Sorry about that.
It's a big presentation.
Oh, yes, that could be why that it's taking a little bit of time. But as soon as it shows, I'll let you know.
Okay, thanks. What I may do is just, in the interests of time, is to continue speaking without slides, if that's okay. And then once it's loaded, we can just carry on with that. Oh, I think something's happening.
Yeah, it's showing now. It's loaded.
Yeah, so I've only got the title slide here. Is this not?
So Dr. Stoessl, sorry,
Yeah.
I'm just, I put the slides on, so it's not through your screen share, but it's through the platform. So I'm not sure whether this would be okay for you. You'll just have to click the arrow buttons at the bottom there to skip through the slides.
Oh, okay, so we're not using my slide set, we're using the slightly older one? Okay, I don't see any arrows at the bottom is the problem. Oh, here we are. Okay, So I'll just go through quickly, just to make the point that I think has already been made, that Parkinson's is a very common problem. And right now, this is from one study that was actually led by Dr. Lang's colleague in Toronto, Connie Maris, that currently it's thought that there will be approximately 1 million people this year, and that's going to grow by another, say, 25% over the next 10 years. And this is from a general national burden of disease, or global burden of disease survey looking at Parkinson's. And what you can see is that the estimate was in 2016, there were more than 6 million people around the world with Parkinson's disease, and this number is growing. And this does not simply reflect the fact that people are surviving longer. So it may reflect something else going on that's contributing to Parkinson's. So it really is a massive challenge, not only for individuals who live with Parkinson's and those of us who are involved in the treatment of Parkinson's, but this starts to become really a public health challenge. I'm not sure how well you can see that. And unfortunately, I can't see it very well now. But this is very, very similar to a slide that Dr. Lang showed, pointing to the various genetic factors that have been identified. And you can see there's a very large list, but many of these are quite rare and have not been reproduced in more than 1 or 2 families. The real importance of identifying different genetic factors is not so that you identify yet another genetic cause, but rather by looking at the different pathways that are associated with these genetic causes, you can start to find common pathways that may contribute to disease, and that may allow one to identify novel therapeutic targets. And we're actually already seeing that start to emerge. Additionally, as Dr. Lang alluded to, there may be treatments that may be helpful in one group of people, but not in another group. And so that can be helpful here. Dr. Lang showed some slightly different slides, but related in terms of concept. This is a slide from a study that appeared last year, looking at the effects of injecting alpha-synuclein fibrils into the gut of rodents. And you can see that in the normal situation, if you inject these so-called preformed fibrils, that you get propagation of pathology up to the brain, and it actually affects the normal alpha-synuclein in the brain so that it becomes abnormal. If you prevent that transport by cutting the vagus nerves, a procedure that used to be done routinely, by the way, for treatment of ulcer disease, but hasn't been done for that for many years now, you no longer get the propagation of pathology. So you still have the endogenous, in other words, the alpha-synuclein that's supposed to be there, but it doesn't become pathological. And then, of course, if you look at mice where the endogenous alpha-synuclein has been taken away by genetic engineering, and you inject the preformed fibrils, nothing happens, because you need the brain's own alpha-synuclein as a template for the pathology to occur. It's quite difficult for me to read these slides at this point, since I'm no longer operating off a full screen, but what this shows is that there is a propagation of pathology starting at the low end of the brain and moving forward over time, as has been suggested by other work. In related work, there is actually, oh, thank you. In related work, there is evidence for interaction between some of the genetic causes. This happens to be an extremely rare genetic cause of Parkinson's, but the gene has a role in mediating inflammation. And so these mice, where the gene has been knocked out, are actually more prone to damage from an infection in the gut. And that's going to be quite relevant to some of the other stuff I talk about. Now, the pathogenesis of Parkinson's is an extremely complicated topic, so I'm really not going to dive into it in detail, but I'm going to spend a fair bit of time talking about biomarkers, which came up in both Tony Lang's and Matt's talks, because we need biomarkers for a variety of reasons. One is to make a diagnosis, not in routine clinic. In clinical practice, we make the diagnosis based on history and examination, and I want to emphasize that because that is still the gold standard. However, you can imagine that if you want to enter people into a study looking at whether a new intervention helps delay the progression or not, it's critical then that you exclude other diagnoses that may masquerade as Parkinson's. So that's one need. The other need is to identify people at the earliest stages. And although Dr. Lang appropriately said that we're not yet at the stage where we should be treating people before they get disease, it's entirely reasonable to think that we might be there in the near future. And so it would be optimal if we had a biomarker that could identify disease before people actually get it, and then apply these novel treatments. Thirdly, and very importantly, we need ways, independent measures of disease severity. That came up in the questions of Matt, is how do you monitor disease progression? Well, it's complicated. It's not straightforward. And it would be great if we had independent markers other than just our clinical assessment. So one of the means that has been looked at is the protein alpha-synuclein that is abnormal in Parkinson's, is to actually measure it. And the classic, if you will, way of doing that would be in the cerebrospinal fluid. That means you have to have a spinal tap, which is probably not high on everybody's list for something to do. But you can see when you do that, there's a difference between healthy and people with Parkinson's disease. The levels are actually of total alpha-synuclein are actually lower in people with Parkinson's. But this is probably not good enough as a diagnostic test, nor would you particularly want to do it as a diagnostic test. But the real issue here is you can see it doesn't change over time. So as a readout for disease progression, it's unfortunately not very helpful. Another marker that has attracted an enormous amount of attention in neurological disease, neurodegenerative disease, is called neurofilament light. This is associated with axons, the long tails at the end of nerve cells. And so anything that damages the axon may result in elevated levels of neurofilament light. And that's actually what you see here. These are healthy controls. There is a bit of an increase over time related to aging, but you can see that people who have other neurodegenerative diseases have quite a marked elevation in levels of neurofilament light. In Parkinson's, there is a mild elevation, but it tends to only become apparent at around the time of diagnosis. And then the increase is more an age-related increase rather than reflecting the severity of the disease per se. As far as we can tell, there are some caveats with that. There probably is some reflection of very severe disease. And this just shows that you may be able to get similar information from measuring NFL in blood compared to spinal fluid. And over time, you can see that most of the changes are occurring in the people with other neurological disease. In Parkinson's, there is some progression, and it's similar between those people who have genetic forms of Parkinson's and those with sporadic disease. Now, this is quite an interesting one because it should theoretically be a fairly straightforward measure, but it's still not considered gold standard. This is actually work done by Alain Daguerre at the Montreal Neurological Institute using MRI to measure loss of brain tissue over time. And they've identified a pattern of atrophy. And I should say that historically people have felt that there isn't significant loss of tissue with Parkinson's, but they've used a specialized technique. So they've identified this pattern, and some people have a lot of atrophy, some people have very little, and some people are in between. And you can see that the people who have a lot of atrophy progress more rapidly in terms of motor severity and cognitive impairment. And this is true even if you use, say, a less state-of-the-art MRI system. And if you compare this against other imaging measures that have been used to look at progression over time, this one stacks up very well. This is something called a receiver operating characteristics curve, and I'm going to return to it later. It's an important concept. The details of this slide, like many of the slides I'm going to show, are actually not that important. It's just to let you know that there are all kinds of things happening. So the slide I just showed you looks at so-called structure in the brain, but looking at function is important. And in this particular case, the investigators are looking at functional connectivity within one brain region, within one so-called network, and between networks. And there is some relationship between the progression of these connectivity changes, not only within the sensory motor network shown here, or between networks here. These are networks involved in more cognitive functions, and how people progress over time. On the right is a different study, which is really fascinating because the authors looked at functional connectivity again, looking at different networks from the left side of the slide, and they were able to find changes that were associated with the later development of impulse control disorders. Now, you're all aware that dopamine agonist use, in particular, drugs like pramipexole or ropinirole, can be very effective for symptoms, but may be associated with these really disabling impulse control problems. And these changes that the investigators identified were actually seen in the brain before people went on treatment and correlated very well with the later development of impulsivity. Interesting concept suggests that not everybody is equally prone to developing these complications. And then I've glossed over all the types of MRI scans that can be done. But the standard MRI that is done for clinical purposes is usually looking at structure, but there is additional structural information that can be obtained if you apply specialized analysis approaches. And I'm actually not an expert on this. There are other people at UBC who do this, but there are many centers around the world where there's highly developed expertise looking at different functions. This is a measure called fractional anisotropy. This is looking at neuromelanin. Dr. Lang mentioned melanin in the substantia nigra, and this is looking at iron and another related measure. The point of the slide is that with any one individual measure, you may get a reasonable ability to discriminate between healthy and normal. What you want in these receiver operating characteristic curves is a very steep rise, because that means you are sensitive to detect change at a high degree of specificity. If you only detect the change out here, it means that you won't have much specificity, so it's not that useful to you. And if you aren't sensitive to detect change, it's also not very useful. So a high, steep rise, as we see here. And the point is that you shouldn't be talking about choosing one method over another, because when you combine these different approaches, now you get a highly sensitive and highly specific outcome. Interestingly, one can apply these imaging approaches to predict future cognitive problems in Parkinson's as well. Now, my version of this has cut off. What I'm seeing is cut off on the left. But in these two studies shown here, the investigators have looked at an area of the brain, the so-called basal forebrain, and this is an area that provides cholinergic projections to the rest of the brain. I will talk about cholinergic projections in a moment. And you can see that they can predict, based on the size and other measures in this region, they can predict whether people are more or less likely to develop cognitive impairment. This is another paper that appeared very recently in Movement Disorders, looking at a measure that we've tended to discard actually in the past. We haven't paid much attention to it, is these areas of high intensity that one can see in a fairly standard structural MRI. And these are perivascular spaces. They're spaces around the small blood vessels. And I will return to the potential importance of that later on. But it appears that these may predict future cognitive change. Now, I mentioned that the basal forebrain sends projections that contain acetylcholine to widespread areas of brain, and we think that loss of acetylcholine in the brain contributes to several deficits that may be seen in Parkinson's, including cognitive impairment, olfactory function, the ability to smell, postural stability, and the REM sleep behavior disorder. Now, we actually did a study in people with LRRK2. Dr. Lang mentioned the LRRK2 mutation that is one of the commoner forms of genetic forms of Parkinson's disease. We've been studying people with LRRK2 mutations for many years. And we actually thought if we could study people with these mutations before they develop disease, it would give us great insight into the progression of the disease. And therefore, we could actually look at the trajectory of disease as it moved up through the brain. And so my prediction was that we would see abnormalities in the cholinergic system before people developed motor abnormalities. And in fact, we found exactly the opposite. And it just points to one of the challenges here. It's an interesting observation, interesting enough that it got published in a very high impact journal. But instead of seeing a reduction in activity, what we actually saw was an increase. So these are the green bars. These are people who have a mutation who do not yet have Parkinson's disease, may never develop it for all we know. And the activity here is actually not decreased, it's actually increased. And this particular mutation happens to be associated with a lower prevalence of REM behavior disorder and a lower prevalence of cognitive impairment. And it just gets to the point that I think Dr. Lang was trying to make, is that not everybody with Parkinson's is alike. And people with LRRK2 Parkinson's, despite the fact that it gives us a lot of insight into the disease, may have a different form of disease. This is just work done from colleagues at University of Michigan demonstrating that these cholinergic abnormalities, they've used a somewhat different approach here, are associated with falling versus non-falling and freezing versus non-freezing. And it actually just makes an interesting point that these two problems, although we tend to lump them together, are actually not quite the same thing. You can see that the patterns of abnormality in the brain are different between freezing versus non-freezing and falling versus non-falling. So this is another example, and I've put the picture up here of Daryl Weil, who many of you may know, who's now the lone movement disorders neurologist in Kelowna and exceptionally busy with a very long waiting list. Daryl, many of you may remember from the days when he was a fellow with us, and he was extremely productive, and we tried hard to convince him to stay in Vancouver, but his wife won out. In any event, we were looking at a different chemical in the brain this time, 5-HT, which is serotonin. I'm sure you've all heard of serotonin because it's thought to be involved in mood. It's also thought to potentially play a role in the development of dyskinesias in Parkinson's, not serotonin per se, but the serotonin producing neurons. And again, we were hoping or expecting to see that people who had a LRRK2 mutation but did not have disease would nonetheless have a pre-symptomatic reduction in serotonin nerve terminals in the brain, and that would allow us to look at the trajectory of disease to see an abnormality of serotonin prior to an abnormality of dopamine. But in fact, what we found was exactly the opposite, and the people with LRRK2 mutations actually had increase in the number of serotonin nerve terminals. But in contrast, colleagues of ours across the water, so this paper came from London, England, and Greece, where they looked at a different mutation. This is a mutation in alpha-synuclein, which is an extremely rare one that originated in Sicily and Greece. And you can see here that now they have an abnormality in the serotonin nerve terminals in people who have not yet developed a dopaminergic abnormality. I can't read the slide very well, but so it's completely the opposite to what we've seen in people with a different mutation. And the reason is that this is a different illness. This is an illness where alpha-synuclein is the primary abnormality and probably behaves like an extreme form of typical Parkinson's disease, whereas this is one where the disease behaves differently, and why would there be an increase as opposed to just, say, normal levels? Well, people have had this mutation for their entire life, and so they've had a chance to compensate, and that increase in serotonin nerve terminals may contribute to the compensation. Matt and Tony both raised the issue of inflammation. So this is a very hot area in neurodegeneration in general, and I should say that the whole story of inflammation in Parkinson's really originated with the McGears in Vancouver, inflammation in neurodegeneration in general, and everybody kind of laughed them out of the party and said they were crazy. Now it is so widely accepted that everybody takes it for granted, and they've forgotten, many people have forgotten, the critical contribution that the McGears made. This is work done by colleagues of mine who looked at patients who'd had fetal transplant for Parkinson's. You remember that craze from around 25 years ago. And what they looked at pathology, because a number of these people have since passed on. And so they looked at the pathology at varying durations after the transplant was done. And in people who died a relatively short time after the procedure, there was no abnormal accumulation of alpha-synuclein. That didn't develop until later on. But in everybody, there was evidence of inflammation, even at quite early stages, shown using one method on this side and another method in the lower left. And so what my colleagues have proposed is that inflammation actually may be contributing to the abnormal deposition of alpha-synuclein. So you might think that means why not give everybody anti-inflammatory agents to slow the progression of the disease? And that's exactly what the McGears have proposed for many decades now, in fact. But sadly, there isn't strong evidence to support that. There is some. Matt also talked about our attempts to study inflammation in the brain using brain imaging. This is actually none of this is work from our center. I'm showing work from other centers. So on the left, I think you can't see my cursor, is work done in people with REM behavior disorder. So these are people who act out their dreams, but they don't yet have Parkinson's disease. There's a very high risk of going on to develop Parkinson's or other related disorders. So on the left, the lower panel, you can see evidence of increased inflammation in the brains of people with REM behavior disorder. But on the right, in the upper panel, you will see that unfortunately, the imaging approach that many people use, and this is actually the same type of approach that Matt used in his study, the main difference is based on a genetic variant and has nothing to do with Parkinson's disease here. So there's no difference actually between Parkinson's and controls. The differences that you see between different groups is related to a genetic variant that is of uncertain significance. And on the lower right, you can see another challenge with this whole field is that inflammation is not necessarily always a bad thing. And if you look at the case of Alzheimer's disease, either so-called prodromal Alzheimer's, people who have mild cognitive impairment, or people who have established Alzheimer's with dementia, higher levels of inflammation as detected by brain imaging are actually associated with slower progression, suggesting that the inflammation may in fact have a protective role, and it may be different at different stages of the illness. So it's a complicated problem to look at. I'm going to move on now to talk about treatments, and I'm going to start with symptomatic treatments. This is a study looking at levodopa. Levodopa remains the gold standard for Parkinson's. There's no other treatment that works as well, but as many of you are aware, there have been suggestions over many years that it may actually hasten the progression of the disease. I actually have never believed that. This is a study that looked at what happens if you start levodopa right away versus delaying the start. And you can see that all you do by delaying the start is have more time with abnormal motor function, because it improves as soon as you start. That's the dip in the blue line. And on the bottom right there, you can see that the quality of life is also more impaired in people with a delayed start. And there's no evidence that you actually hasten the progression. So there's no reason to hold off on treatment, but nor is there a reason to start it earlier than you need to. This is looking at inhaled levodopa. So as you all well know, for people who have advanced Parkinson's, they may have unpredictable off times that can be quite difficult to manage with standard therapy. And you need to be able to deliver a drug that can get to the brain quickly. So this is inhaled levodopa, not yet available in Canada. It simply shows that majority of people, a small majority of people, just between 50 and 60% of people do turn on if they're in an off state. But it also shows you that the time is fairly short. They only measured out to around an hour. This is another study of continuous apomorphine. Now, you're probably aware that short-term apomorphine by either injection or more recently sublingual is now available in Canada. This is continuous infusion. It's actually an old treatment. I, in fact, imported apomorphine to Canada privately for management of a patient more than 30 years ago, and we ended up giving it continuously by a pump. But this is a large-scale international study simply showing what you might expect, that there's an improvement in motor function that is fairly sustained. And Dr. Lang talked about the challenges of treating all the other manifestations of Parkinson's. And there's no way that I can cover all of this, but the Movement Disorders Society has published periodic evidence-based reviews of treatments that are available for both the motor symptoms, I'm not going to present those today, but also the non-motor symptoms, which for many people are much more important. Now, I'll just preface this by saying that an evidence-based review means that there's a bar of a certain height for papers to jump over. And sometimes that height is too high. In other words, if the evidence isn't really strong, the people reviewing it will say, well, we don't think it's there yet. So it may be useful, but we don't think you've proven it. And that's really reflected in what we see here. So in the upper left are treatments that are used for managing depression in Parkinson's disease. You'll first of all see that some of these treatments are used for treating the motor features of Parkinson's, but in particular, some dopamine agonists may be helpful, particularly pramipexole. However, you're all aware that there may be risk associated with this. Interestingly, traditional drugs for the management of depression, although they're called possibly useful here, I would say they're probably useful, almost certainly useful, in fact. The evidence is actually not as good as one might hope. A related problem in Parkinson's is apathy, which may occur in the absence of depression, so loss of motivation, loss of interest. And this is a really challenging problem to treat, but it may respond to dopamine agonists or cholinesterase inhibitors that I talked about before when I talked about the acetylcholine projections that are thought to be important for cognition and postural control. Treatment of cognitive impairment in Parkinson's disease is the upper right panel here. And here we do have reasonable evidence that the cholinesterase inhibitors, so donepezil and rivastigmine, probably useful, galantamine, possibly. Memantine is a drug of a completely different class. It's a so-called NMDA antagonist, similar to amantadine, which, by the way, is not a good drug if you're cognitively impaired. These may all be helpful. And then to treat psychosis, we've got a challenge because the traditional drugs to treat psychosis will reliably make Parkinson's worse. They work by blocking the effects of dopamine in the brain. But there are some atypical drugs, clozapine being probably the one with the greatest level of evidence, but it's a difficult drug to use. However, it clearly does work. Quetiapine is not as difficult to use, but the evidence is not as strong. And then pimavanserin has a different mechanism and is unfortunately still not available in Canada, but it should have fewer side effects. We've already talked about the impulse control disorders in Parkinson's. There is actually no treatment that is demonstrated to be useful. You can see that the highest level of evidence, which is still grossly short, is in fact for cognitive behavioral therapy, so not for drugs. So this is a really challenging problem to treat, and one of the reasons that we are now so much more careful about using dopamine agonist medication compared to the past. I'm not going to talk at length about deep brain stimulation surgery. This is certainly, in general, widely accepted. It's recognized that this is useful for carefully selected people with Parkinson's. But even when selecting carefully, it's not a straightforward treatment. There may be side effects. You're basically putting in an electrode and you're stimulating according to the settings that have been set in the clinic. And as a patient, you may have some degree of freedom to adjust up and down. But the brain, that is really based on an assumption that the brain's activity is static, that it's the same all the time. And of course, that can't possibly be true. So one of the recent advances in deep brain stimulation is the idea that instead of just setting up settings that will be used for stimulation, is that you actually use the electrode to record what's happening in the brain, and depending on what you measure, you then adjust the stimulation settings. So you're constantly getting feedback and adjusting the stimulation according to that feedback. That's not yet in prime time, but it is happening. The other thing that I'm not showing a slide of here is that there is increasing interest in directional control of deep brain stimulation so that you can actually shape the area of the brain instead of assuming that it's just a standard spherical glob. This is a treatment that is attracting a lot of interest and is not yet available in British Columbia. For the last several years, people have used MRI-guided focused ultrasound to make a lesion. So typically when we treat movement disorders with surgery, there are two different variables that you can look at. One is where in the brain. The other is how do you do it? One approach is to burn a hole, and traditionally that was done with an electrode. You basically put down a wire, you pass current through it, and it's like frying an egg at the end of the wire. But the other more recent approach is to use ultrasound waves that pass around the head, and where they all intersect, that's the focused ultrasound. And if you deliver enough of it, it will burn a hole. So that has been done for the last several years to treat tremor in one part of the brain called the thalamus. So that's going to be called an ultrasound thalamotomy. This is work done by my colleagues in Spain who took what some would consider to be a slightly braver approach, and they used it to make a hole in the subthalamic nucleus. So for those of you interested in deep brain stimulation surgery, one of the locations, in fact, the most common location these days, is the subthalamic nucleus, or STN. In this case, instead of using DBS, they've burned a hole using ultrasound on one side of the brain, and I want to emphasize that. And you can see that there is quite a substantial improvement in the manifestations of Parkinson's, particularly opposite to the side of the brain where they made the lesion. That would be the blue bars. Now, I want to emphasize the issue of doing this on one side of the brain because we're still very concerned about the risks of making destructive lesions on both sides of the brain. That may be associated with an unacceptable risk of speech impairment and cognitive impairment, possibly postural control. So this is an emerging area. There are limited numbers of reports emerging. There's one that's going to be coming out in movement disorders, but this is still not considered something, most people would not consider that something safe to do on a routine basis, to make lesions on both sides of the brain. On the right side of the slide, you can see a research approach using focused ultrasound, which is really fascinating. You know that one of the challenges we have in treating brain diseases is that the brain is protected from the bloodstream by the blood-brain barrier. That's good for protecting the brain, but it means that it's sometimes difficult to get drugs across, and certainly difficult to get large molecules across. So you can actually use the ultrasound to regionally open up the blood-brain barrier for a limited period of time in just that part of the brain that you want to affect. And in this case, using an animal model, investigators in Toronto have opened up the blood-brain barrier, and it's allowed them to deliver a gene therapy precisely where they want it for just the amount of time that, for a limited amount of time, and then you stop the ultrasound and things go back to normal. This is also using MRI, but in a very different way, and this is the potential conflict that I declared at the beginning. I have nothing to do with this study, but I am the chair of the Data Safety Board for the ongoing study, the double-blind study. So this is using gene therapy to express a gene that's involved in dopamine synthesis. It's actually the gene that converts levodopa to dopamine. So doing it on its own is probably not enough, but you can see that this results in improvements in imaging measures and improvements in motor function. And it's hard for me to show you without control of the cursor, but basically it means that you will respond to a lower dose of levodopa. And once you give a higher dose of levodopa, you will respond for longer. So you may get more sustained benefit from each dose of treatment. This was from a very preliminary study. As I indicated, there are now double-blind trials underway. And Dr. Lang showed a very similar slide. I think the really interesting thing for people with Parkinson's and for investigators in the area is the hope that we may actually have treatments that could modify the course of the disease, not simply control the symptoms. This shows a listing of some of the approaches. So this is an example of why understanding the genetics of Parkinson's is important. LRRK2 is one of the commoner mutations. There are now drugs in development that reduce the activity of the enzyme associated with LRRK2. I want to emphasize, these are in the earliest stages of testing. These are not drugs that would be available for people, but there has been interest that they might actually be useful even in people who have Parkinson's unrelated to LRRK2 mutation. And the same is true for the next entry on the table is glucocerebrosidase. This is GBA, which is thought to play a role in the clearance of alpha-synuclein from the brain. And there are a number of treatments that are currently being tested, also treatments being tested for alpha-synuclein. And I just want to remind you that this is not always straightforward. GDNF has been around for many years. There were early claims of fantastic benefit, followed by claims of no benefit. And of course, the truth may be somewhere in between, but this is from a recent double-blind study showing that although there was marked improvement in the PET scans, shown on the bottom right, the trial failed to meet its primary outcome measure, which was the improvement in motor function. Now, that's actually a little bit more nuanced, because if you do a more specialized analysis, looking at longer time periods, combining a bunch of measures, of different measures, there may be some signals. So this is not dead. In fact, there are a number of people still interested in pursuing this as a potential treatment for Parkinson's. And this is a different approach to replacing GDNF. Instead of putting the protein into the brain, you actually use gene therapy. There are no clinical results here, but you can see on the right that the imaging measures do improve if you put the gene expressing GDNF into the brain. However, lots of claims are made, and life is unfortunately full of disappointments. So this is one that got an enormous amount of publicity a few years ago. The suggestion that if you block calcium channels in the brain with drugs that are already available on the market, that it's going to halt Parkinson's in its tracks. Unfortunately, when people actually did the study, there was no benefit, shown most clearly on the panel on the right there. You can see no difference between the drug and the placebo group. This is another one that Dr. Lang also mentioned that has had an enormous amount of publicity, and I think it points to the challenges of preliminary publicity, of overly optimistic publicity. So this is nilotinib, which is a cancer drug on the market. All kinds of claims were made a couple of years ago. This is from the more optimistic of the two studies that have appeared in the last year. This shows small improvements in biochemical measures, really small improvements. But when you actually look at the clinical measures in the upper right panel, and you have to go into the supplementary information to get this, it's not in the main body of the paper, there's absolutely no improvement whatsoever. And this is from the people who were enthusiastic about it. It seems to be relatively well tolerated. This, however, is from another study that has only been published on what's called a preprint server. So it's not appeared in a full journal yet. And it basically shows absolutely no improvement and suggests that while the drug may have adequate levels in the blood, it may not get into the brain to a sufficient degree to do what it wants. This is another example, exenatide, a drug that's used for diabetes. If you just look at the right half of the slide first, you will see that the change from baseline, which was the main outcome that the authors reported, it appears that it was beneficial. So the blue line, just focus on the right side of the slide. The blue line shows the active treatment, shows a reduction in motor symptom burden, whereas the red line suggests that the placebo group is continuing to get worse. But if you actually look at the absolute measures, this is just looking at motor function, on the left half of the slide, you'll see that basically the two groups converge. There are other issues with this study that I won't talk about now, but there is no evidence yet that it is neuroprotective. That's not to say there won't be evidence of that in the future. This is yet another one, very, very complicated looking slide, but there's a reason behind that. This is for the drug terazosin. This study came out, I think, about a year and a half ago, nearly 2 years ago now, in a very prestigious journal. And the authors started with basics. They looked at the effects of the drug terazosin, which is used for prostate, for bladder disease. And they showed that it stimulated the capacity to produce energy. So they then went on, and in a very large number of animal models that I'm not going to show you here, I'm only showing a couple, they showed that it was protective against the effects of treatments that typically damage dopamine neurons. They then, in the middle panel, did something really interesting. They looked at cell lines from people with LRRK2 mutations, and they found that this drug in the test tube could actually reduce the abnormal expression of alpha-synuclein and increase energy production capacity within the cells. And then if you now look at the far right of the slide, they looked at data from the Parkinson's Progression Marker Initiative, PPMI, that is sponsored by the Fox Foundation in the US. And they retrospectively looked at people who were receiving terazosin or similar drugs and those who were not. And they found in the red line that people who were receiving terazosin seemed to progress more slowly. But this is only a handful of subjects. So it's really not adequate. So then they went and looked in the bottom right hand of the slide. They looked at a large insurance cohort of people where they can get information on tens of thousands of people who get these drugs. And they found that the people who were getting the drugs were less likely to develop Parkinson's. And if they already had Parkinson's, they were less likely to develop certain complications. So very well done study by serious authors published in a very prestigious journal, but it's not clear. There's certainly inadequate evidence at this point to recommend it. And these drugs are not without side effects. They can lower the blood pressure, which is already a challenge in Parkinson's. This is a potentially exciting one. This is using antibodies against alpha-synuclein. I'll just quickly cut to the chase and say these are all at preliminary stages. There's evidence so far that they are probably reasonably safe, insufficient evidence to say that they are effective at slowing the progression. So antibodies is one way. The other approach is a paper that just appeared a couple of months ago in Lancet Neurology, is to get the body to produce its own antibodies. And we do that with vaccines, right? That's how they work, is you give something that will stimulate an immune response, the body produces antibodies, which should then mop up in this case, the abnormal synuclein. And again, this was designed as a safety study, and it did show that it was safe. There's way too little information to say that it's effective, but there were some promising early signals to suggest that that may be the case. So certainly something to keep an eye on. This is a small molecule that interferes with alpha-synuclein. I'm not going to spend any more time on this. These, however, are kind of interesting. This is a drug, ambroxol, that's used as a cough medicine, but it is a so-called chaperone for glucocerebrosidase. So for people who have GBA mutations, this may help raise the levels or the effectiveness in the brain. And the authors have presented very preliminary evidence to suggest that there may be some impact if you give this treatment, but there was no placebo group here. They basically gave increasing doses of active drug. It's certainly an area that's interesting to keep watching because it appears to be quite safe. And this is a summary slide from a paper that came out quite recently in the Journal of Parkinson's Disease, just looking at all the treatments that are in the pipeline. And you can see there's a very large number of them. Sadly, I would say most of them are focused on treating symptoms, those in the bottom half of the slide, and fewer that are focused on slowing the progression or modifying disease, but we've talked about a number of those today so far. I've shown this slide not because I want to promote this study, but because I imagine that some of you may be aware of it. This is a really problematic study where a patient paid to have the research done on himself with induced pluripotent stem cells, and I would just say the evidence is completely inadequate. How am I doing time-wise?
We are over time,
okay.
Dr. Stoessl, and there are a couple of questions if it's all right. If you would like to, just to conclude, and then we'll ask a couple questions before we close.
The last section is in some ways the most interesting, but it can easily be summarized very quickly. And that is to say that despite the fact that we don't have new drugs yet, there are things we can do. So you already heard from Naomi and Matt about the importance of exercise. There is some interesting evidence emerging that diet may have an impact. And the other thing is sleep. And sleep is when we clear the abnormal proteins from the brain. I showed you near the beginning, the perivascular spaces, the spaces around the vessels in the brain. Those are thought to be important for clearing abnormal proteins. And sleep is important for that. So getting plenty of regular sleep is actually an important thing to do. Not something I do, but you should. So I think I'd just close by saying there's a lot of progress being made. I think cure is an overly simplistic and optimistic concept, but there is hope for disease modification. And just one more plug is the only way we're going to learn more is if we collect and share information, because we need large numbers to really draw conclusions. And the Parkinson's Canada, together with Brain Canada, is sponsoring the Canadian Open Parkinson Network, in which many of the centers across the country, including ours, are involved. And so there's now a web-based entry for that, and I encourage you all to think about that. So I'm sorry I've gone over time. I'm happy to deal with questions if you can tolerate any more time.
Just a couple of quick ones. That was obviously a very informative and packed presentation, and I think encouraging to the Parkinson's community that so much is happening. One of the therapies for more advanced Parkinson's disease that you didn't mention was duodopa therapy. Could you speak to that briefly, please?
Yeah, so duodopa is basically a way of continuously infusing levodopa. It's the levodopa is still the best available treatment for Parkinson's, and the problem is that there are fluctuations in response. So duodopa tries to get around that. It is, however, a very expensive treatment, and it's also very fiddly because it involves these tiny little tubes that get put into the gut and are then attached to a pump. And those tubes are subject to getting kinked, blocked. They may need to be replaced. So it is it can be very helpful for some people, but I would say people have to be quite carefully selected. And as you well know, in BC, it's only a very limited number of people who get funded for it, and it is expensive.
Yes, there's some advocacy work going on to try and increase the numbers. Is there a medication, just moving on very quickly here to a few other questions, are there any drugs that are specifically helpful for the prevention of falls?
That's a very good question. So there has been a lot of discussion about using the cholinesterase inhibitors. I showed evidence that the postural instability is associated with a deficit in acetylcholine. There have been some studies to show that the cholinesterase inhibitors may help a bit with postural instability, but that is a little bit controversial, and it likely won't apply to all people. So there's no magic. I mean, probably the first thing is to make sure that the falls are not associated with off times. So although historically we say that levodopa doesn't help postural stability, if people are clearly freezing and that's when they fall, and that can be improved by dopaminergic medication, then the first thing to do is to adjust that. The other thing is related to what Naomi was doing, the dual tasking. So people with Parkinson's are maybe quite good at doing one thing at a time, but have great difficulty with dual tasking. So first of all, from a rehabilitation perspective, there is emerging evidence that you should try to focus on dual tasking, which is what Naomi was trying to do. But from a day-to-day therapy perspective, you actually want to discourage people from trying to dual task when they're on their feet. So if you have advanced Parkinson's and you're falling, you need to concentrate when you're up on your feet. You need to focus on staying upright and not be paying attention to the conversation going on around you or what's on the television or whatever else is happening in your environment. You just think about staying upright.
Okay. All right. Well, we are right out of time. We do have a couple other questions that staff will respond to. We have some of those resources, folks, so we will get back in touch with you. Thank you once again, Dr. Stoessl, for a very comprehensive and informative presentation. We're very appreciative of your time.
Okay,
You have a great day.
Everybody enjoy
right.
your lunch now. Okay, bye-bye.
Yes, and everybody's home. So I'm just going to take a few minutes just to close. First of all, before we do, I'd like to, and we did have an early bird registration draw and some prizes were connected with that. So there's a screen that we're just going to put up here. If you are here and one of the lucky winners, you're very welcome to connect with us and arrange for getting the prize delivered to you. If you're not here, we will reach out to you folks. I know, Annalie, I saw you, so we'll have to see about how we can get that smart speaker with Alexa to you. Other folks, I'm sorry I didn't catch your names there, so we will reach out to the other folks who weren't able to attend today, even though they registered early. So thank you, everyone, for taking time to attend this virtual conference. We hope to see you in person next year. However, we have no idea what it will be like. So getting your feedback on this virtual event would really be appreciated. If you could take a moment to give us your thoughts. Once the conference is closed, you'll be taken to an evaluation survey. So after you do that, it will only take you a couple minutes. And again, we'd really appreciate it. Please do have a wonderful afternoon then and stay safe. Goodbye for now.